Thank you again to Medtronic for putting this session together. I'm going to shift gears a little bit and talk about pelvic venous disorders. These are my disclosures. So for those of you who attended the session yesterday on pelvic venous disorders, they sort of talked a little bit about some of the symptoms that kind of correlate with patients who present with this. There's been a lot of terminology in the past where we refer to this as pelvic congestion syndrome, pelvic venous insufficiency, pelvic venous hypertension, all sorts of things. And it really comes down to kind of collectively naming it as collective pelvic venous disorders. And so as you all know, some of the symptoms that women tend to present with is chronic pelvic pain that is described as a heaviness, sensation in their lower pelvis that's worse with standing, being upright, and then is relieved in recumbent situations. In terms of the anatomy, again, when we look at the different types of zones, zone 1 is termed by reflux within the renal vein system, zone 2 by the gonadal and internal iliac venous system, and then down lower in zone 3 to pelvic origin and extrapelvic veins. And then we can also get chronic pelvic pain for women who have left common iliac vein compression or nivel lesions that can lead to reflux into the pelvic venous system. At Mayo Clinic, we actually have a chronic pelvic pain multidisciplinary conference. So I actually work with my gynecologist in terms of really determining the best treatment care plan for these patients. So one of the things that they actually do is they actually look for dilated pelvic varicosities when they take patients, for example, when they're looking for endometriosis. And so we can work together to determine whether indeed they see dilated varicose veins and the patient may need treatment down the line if they become symptomatic. So we all see some imaging that can result from things like this. In this situation, we can see dilated gonadal veins on the left and the right side. And the question really becomes, when do you start intervening with these patients, particularly when they present with chronic pelvic pain? And I think a really good way to think about it is to think about compensation or uncompensation. So an uncompensated ovarian vein reflux, it can lead to high pelvic venous reflux. And when you start to have compensated ovarian vein reflux, there's a pressurized system. So it kind of pressurizes into the lower pelvis. It goes out to escape points. It can lead to, for example, patients presenting with vulvar varicosities. And then the similar with uncompensated left common iliac vein obstruction. Those patients have leg pain. And again, when you start to have compensated left common iliac vein obstruction, again, that leads to a pressurized system leading to pelvic venous hypertension. So these are just some of the cases. This is a female in her late 30s. She's multiparous, G5-P5. She presented with chronic pelvic pain that was worse during the day and while in the upright position. And she had increased pain with each pregnancy, dyspareunia. She did have pain on both sides. This was her baseline imaging, and you can see here there's dilated varicose veins, particularly on both sides, within the gonadal vein system. On venography, you can see the ovarian vein is dilated, and there is congestion of the ovarian plexus along with uterine venous engorgement. So we ended up embolizing both the right and left ovarian veins in this particular patient. And the patient in follow-up had complete resolution of her pain. And this is case number 2. This was a female in her mid-30s. She was multiparous, G3-P3, had chronic pelvic pain worse during the day and while in the upright position. And she was diagnosed and treated for pelvic venous insufficiency at an outside institution. And so these were her images when she came to clinic. You can see here that she had bilateral gonadal vein embolization performed outside. And so the important thing is to really think about, again, other sites of reflux that can occur in these patients. And so if you look on the image here, you can see there is a connection between internal iliac vein and the gonadal veins, again, going back to the zones that I talked about earlier. So in this case, we went into the internal iliac veins. We found these varicosities that were identified, and then we went ahead and coiled them. She also had complete resolution of her symptoms once we did that. And then case number 3 is kind of an illustration to really just kind of go over some of the things that are important when you do a workup. So this was a female in her mid-40s. She was multi-para. She had chronic left-sided pelvic pain. Pain was worse during the day and while in the upright position. And you can see here on her cross-sectional imaging, she did have some dilated veins only on the left side that kind of correlated along with her pelvic pain. And so in this case, we saw a dilated left gonadal vein that was refluxing. And in this case, we performed a diagnostic pelvic venogram just to make sure that there was no internal iliac venous reflux in this sign, that she didn't have any underlying nivel lesion. And so that you can see that on the image on the right. So we went ahead and just proceeded with gonadal vein embolization. And this is the last case. This is a female in her mid-40s. She was multiparous G3P3. She had chronic left-sided pelvic pain. And the pain returned following treatment for an underlying left common iliac vein compression. So she was initially stented at an outside institution, and she did have persistent left-sided symptoms. So in this case, you can see the venogram and you can see the indwelling stent that was placed for a nivel lesion, but she had persistent left-sided pain. She did have reflux in her left gonadal vein. So we ended up coiling the left gonadal vein. And so the combination of both treatment of the nivel and gonadal vein embolization really led to her relief of symptoms. For some of you that haven't seen this paper, it was the consensus statement that came out on the management of nivel lesions. And stent placement for nivels has a role in cases with quality of life impacting chronic pelvic pain of venous origin in the presence of dilated periuterine veins. There has been a spattering of retrospective case reports that have been reported in the literature that have kind of shown how other symptoms can be related to patients who present with left common iliac vein compression and chronic pelvic pain. And these can range from headaches and brain fog to POTS to orthostatic intolerance to fatigue, IBS, feelings of physical anxiety, prolonged dyspareunia, and interstitial cystitis. And all of these have really been retrospective case reports in the literature. So clearly further research needs to be done in that. So I'm just going to quickly kind of go through some of the data that we completed as a prospective. It was multi-site, 5 U.S. sites ran a clinical trial where we looked at the presence and severity of comorbid conditions in patients who were referred for the treatment of pelvic venous disorders, and really to determine pelvic vein abnormalities, if by treating them it can result in symptom improvement in other ways. So again, we had 5 sites across the U.S. This was a prospective trial. Treatment involved either iliac vein stenting or ovarian vein embolization. And then we looked at standardized quality of life surveys that were given to these patients, both at baseline, 3, 6, and 12 months post-treatment. And then we looked at the results. These were the surveys that we used. It was the IPPS or PCS study, like the International Pelvic Pain and Pelvic Pain Assessment Forms, the PUF study, and the POTS, postural orthostatic tachycardia syndrome, and the Rome-4 IBS surveys were all used in these patients. And this was our data. We had the mean age was 35. Interventions performed, we had 49 stents placed, 9 patients received embolization, and 1 patient received both. There was no post-procedural complications, and across all 5 sites, there was 1-year stent patency at 100%. And you can see here the all surveys, all patients had improvement from all surveys at 3 months that was actually sustained across to a year, with the IPPS and PCS scoring survey at the highest level, but also improvement in POTS, Rome, PUF, and ANC scores. So this was just when we looked at specific symptoms that improved, and you can see the improvement in symptoms was primarily in the burning vaginal pain and pain, pelvic pain and pain after periods that was improved and sustained at the 12 months. But even so, if you look here, muscle and joint pain and low back pain also improved. So not to the same level, but it did decrease at 3 months and was also sustained at a year out. When we looked at the PCS scoring system, again, you can see significant improvement at 3 months, sustained out to 12 months. and again, with some improvement in all symptoms there. So in conclusion, and some key learning points, pelvic venous disorders should be considered in the workup for patients with pelvic pain. I do think it's a multidisciplinary care where we should be looking at these patients similar ways that we have interdisciplinary HCC conferences. It's a full comprehensive pelvic evaluation and follow-up is necessary. And we should think about PEVD, considering the differential as a contributing factor to other symptoms besides pelvic pain. And clearly, prospective clinical randomized trials in patients is needed with these symptoms. Thank you.
Thank you very much for this really excellent talk. From my side, some questions. First of all, how do you size the coils? The veins normally have between 4, 5, 6, up to 10 millimeter. How do you size them? How long are they? And how many coils normally do you use?
Is it on? Okay. So I think, obviously every patient's going to be different. So I usually measure it on the venogram to really determine the sizing. I've actually switched to placing a pod at the distal end and then using various coils. I do use the sandwich technique because I think there has been shown in data that has better results from doing that. So it really depends, but I like to use a distal pod and then maybe 2 coils and then use STS foam and then coils all the way to the top.
And do you always also inject the foam in the periuterine veins very down there, or do you always start with coils and then coming up with the? No,
I usually look down there on the initial venogram to look for all those pelvic venous system and the congestion, and look for reflux, look for crossover, things like that.
And do you always do both sides, or at least look at both sides, or do you just there's only left side in the imaging before you end up on the left side?
So I usually do a full diagnostic pelvic venogram in my patients, especially if I think they may have a combination of a nivel lesion along with gonadal veins. So I do a full assessment. If the gonadal veins are seen to be enlarged on the cross-sectional imaging, and for example, if the patient has left-sided pelvic pain, I tend to be more conservative and treat the left-sided system, but I also look to see if she has an underlying left common iliac vein compression.
And the full pelvic imaging before, does it mean you also inject contrast media in the internal iliac veins and in the common iliac vein in order to image all the iliac veins?
Yes. So I do full injection of internal iliac veins, and then I use IVUS also, both left and right side system, and gonadal veins.
With the IVUS, you look for the compression of the left common iliac vein, or you also look to other parts of the venous system?
No, I look for a left common iliac vein compression. The reason I do it on the right is really to size the stent to what the normal vein size is in these patients.
Mm-hmm. Oh, Mike, you're the Mr. Liquid. Do you always, in some patients, use coils, or do you always use liquids, or what do you think about? And the question back to you afterwards, do you sometimes use liquids?
I move to liquids for most of all patients, but I would say that when I use coils, I use for proximal protection mainly. Or if we talk about ovarian veins, and then I go through and then I use liquids. And for because I systematically checked both hypogastric veins to see if there is no escape points or uterine varices, and in that case, because the flow is, we have a retrograde flow which is quite direct and probably a bit more risky. In that case, I do the same. I use, it's a combination, either only coils or coils plus liquids for the distal part, and coils just to protect the proximal one. But oftentimes it's a combination.
Yeah, I think we talked about this also yesterday at the pelvic venous session. There was a lot of questions about glue. We don't use glue. Again, it was talked about yesterday. It's very expensive in the US, so we just use STS. But I think you've used glue in some cases.
Yeah. To me, the rationale is the same if we use cyanoacrylates or copolymer, so we can use both. We use onyx as well for PCS. With the same rationale. We know the advantages and drawbacks of each of them, but to me, the advantage is the same in terms of occlusion. And I really prefer occlusive liquids than just STS or sclerosing agents, especially for big veins.